Greetings, I'm Dr. Pang Hong Wu from Untitled General Hospital. I'm representing Nanarori Gangnam Hospital in this presentation of endoscopic transforaminal lumbar interbody fusion achieve improved radiological and clinical outcome compared to open microscopic transforaminal lumbar interbody fusion, a retrospective case study. An aging population leads to an increased incidence of degenerative spinal conditions. Minimally invasive surgery is gaining traction as a choice of treatment for patients who require interbody fusion. Endoscopic fusion is one of the least invasive methods of fusion. And there are two main groups of endoscopic fusion using uniportal endoscopic technique. One is the transforaminal route of endoscopic fusion technique, often using local anesthesia. And another group is a uniportal full endoscopic approach to perform posterolateral transforaminal lumbar interbody fusion, EndoTLIF, we call with facet, full facet with resection. In this study, we aim to perform comparative cohort study evaluation of the fusion rate, subsidence rate, and clinical outcome of EndoTLIF in comparison to microscopic, minimally invasive transforaminal lumbar interbody fusion, TLIF, in short for single-level lumbar interbody fusion. We included patients who underwent single-level uniportal endoscopic posterolateral lumbar interbody fusion, EndoTLIF surgeries, and microscopic minimally invasive TLIF surgery who presented with neurogenic claudication and back pain with minimum of 6 weeks of conservative treatment failed conservative treatment. They often present with grade 2 and below spondylolisthesis, which were included spinal stenosis with and without instability, adjacent segment disease, and recurrent disc herniations. We excluded patients who had previous spinal fusion surgery, who had trauma leading to the need of fusion, revision, spinal fusion surgery, tumor, infection, pseudoarthrosis, congenital spinal deformity, and significant scoliosis. This is a video showing how an endoscopic fusion is performed. We dock at L45 junction when with the full exposure of the facet joint using the endoscope, and then we drill from the this is the Wood's point, which is by spinal laminar junction, towards the Kim's point, which is the outer layer of the facet joint between the superior and inferior articular facet, drilling through the isthmus. Once the completion of the drilling is performed, we use the retractor, which is the working retractor, to perform elevating maneuver and retrieve the inferior articular facet followed by superior articular facet. We complete the flavectomy to expose underlying disc space. As we can see here, we use the radiofrequency ablator to expose the disc space and rotate the working cannula to protect the traversing nerve root. Use the drill to start off the discectomy, and using the mixture of forceps and probes, we complete the denudation of the cartilage of the interbody space, intervertebral space, to prepare the end plate for accepting an interbody cage. As you can see here, we use the probes. We are gentle in dealing with the end plate to prevent end plate fracture, which is one of the reasons for subsidence. Under a magnified scope view, we can visualize very well the end plate and perform fusion surgery well. And finally, we will insert the cage. and perform hemostasis and evaluate the position of the cage as well as that of the end plate status and dura. After surgery, we use the Kim staging system for fusion status to evaluate. With Kim stage 1, we name as end plate preserved stage, where you can see the end plate is still intact, and stage 2, right, which is the end plate opening stage, where we can show that there is no clear definition of the rim of end plate directly above and below the cage, and the graft in the cage is not continuous with the end plate of the bone yet. Stage 3 is when there is bilateral sclerosis, when both of the end plate adjacent to the cage show some sclerosis, and the graft of the cage is continuous with the end plates. And the stage 4, when we call it the fusion bridging stages, when the fusion bridge formation stage, where there is extensive sclerosis in both end plates as well as continuous bone from the graft to the adjacent cage area. We grade subsidence into 4 grade 0 no subsidence, grade 1 mild subsidence 10%, grade 2 is moderate subsidence up to 25%, 24%, and more than 25% severe subsidence. We of course use also the Bridwell grade fusion grade status. We measure the VAS and McNabb score as well as ODI, the pre-op 3 months and final follow-up. In our results, we find that in both groups there is a statistically significant improvement in terms of the VAS and ODI. However, comparing the two groups, we find that there is improvement, statistical improvement, more in the EndoTLIF group in terms of Bridwell fusion grade at 6 months, 1 year, Kim fusion grade at 6 months and 1 year, and they have less subsidence in the EndoTLIF group at 6 months and 1 year. There is also better VAS and ODI score in the EndoTLIF group at 3 months and final follow-up. It's of interest that there is a trend that the ODI and VAS improve at 1 week, but there is no statistical significance. This is another group that shows the mean difference, showing that with EndoTLIF and versus TLIF, they do better in terms of Bridwell grade and Kim stage subsidence, as well as VAS and ODI at 3 months. There's no comparison study in the uniportal posterolateral facet sacrificing EndoTLIF with microscopic EndoTLIF, TLIF, microscopic TLIF. The reasons for better early fusion data as well as clinical outcome in our series are multifactorial. One is that with endoscopic preparation, we allow visualization of end plate under magnification. We allow the optimized size 3D printed cage with the assistance of endoscope to perform the fusion. Autograft and allograft mixtures are added to overcome the lower amount of autograft harvested with the MIS TLIF. These are useful in our technique. We find that there is a lower mean grade of subsidence in our series as well. One of the reasons is probably due to magnified, visualized, proper end plate preparation, and we don't need to use QRAT in EndoTLIF, which may damage the end plate. Overall, our conclusion is the application of uniportal endoscopic posterolateral lumbar interbody fusion EndoTLIF achieve comparable clinical outcomes and better fusion with less subsidence and microscopic MIS TLIF in the midterm evaluation of our cohort of patients. Our paper is accepted in Global Spine Journal, is pending publications. If there's any question, please highlight to me. Thank you very much for allowing me to share our data with you. Thank you.